Dr. Sagar Lad. He's done his MBBS DNB DCH, Fellowship in Neonatology Australia, Pediatric Critical Care Medicine Australia, Consultant Pediatric Intensivist and Neonatologist Jahangir Apollo Hospital Pune, Advanced Training in Pediatric Critical Care from Children's Hospital Westmead Sydney Australia, Fellowship in Neonatology from University of Sydney Australia, contributed as an author in IAP textbook of Pediatric Intensive Care, IAP PICU protocol, textbook of Basic Pediatric Intensive Care course and practical approach to PICU.
Thank you, madam. This is the last lecture, so everybody is tired, so I will be very fast. This is a pulse oximetry screening for to diagnose a critical congenital heart disease. Now, what I am going to discuss the prevalence and scope of the problem of missed or untimely diagnosis of critical congenital heart disease, to discuss the evidence supporting the routine use of pulse oximetry in the newborn and to detect the CCHD, and to discuss the benefit as well as the limitation for the type of this screening. Now, there are two terminology, congenital heart disease and critical congenital heart disease. So, this is basically we should use a pulse oximeter to diagnose the both, but critical congenital heart disease is the emergency, dial emergency. Now, the incidence of congenital heart disease is about 1 in 1000 babies, and at least 8 to 10 per 1000 have an anomaly, has got this anomaly with a clinical impact. The incidence of CCHD is about 2 babies per 1000 live birth, and which has got a duct dependent lesion. And the duct dependent cardiac lesion, these are very difficult to diagnose even before the discharge. And most of the discharge is usually babies are discharged before the 72 hours, and which is about when the ductus arteriosus is going to close. So, when these babies goes home, they presented with circulatory collapse, respiratory compromise, metabolic acidosis, and sudden death also. And once the CHD who present in a serious deteriorated condition, the survival and mortality is very high. The survival chances goes down. So, what is the incidence? How many critical congenital heart disease are missed? In about UK, there are about 20% of the total babies who went home discharged without any diagnosis, and then they presented with a CCHD. But in India, we don't have exact figures, but all the antenatal scan and very important in the postnatal examination of a baby that will give us an idea whether the baby is going to develop a problem or not. So, this is a picture which is showing that a prenatal ultrasound can detect about 50 to 60% of the babies with a critical congenital heart disease. Physical examination, always never forget to check the femorals of the baby before we are going to discharge the baby. So, the clinical examination or physical examination will detect about 20 to 25%, and remaining 20 to 25% of this CCHD can be picked up by the pulse oximetry. Now, there are only two types of lesion, either it is the right sided lesion or the left sided lesion. So, critical congenital heart disease can present as a right sided obstructive lesion, which are generally presented as a cyanosis, and we know that TAPVC, supradiaphragmatic variety, TGA, truncus arteriosus, they are generally presented as a cyanosis. On the other hand, the diseases on the on the left side generally presented as a shock, like a hypoplastic left heart syndrome or the coarctation of aorta. So, this is a list of the diseases that usually we are targeting by doing the pulse oximetry screening. So, hypoplastic left heart, pulmonary atresia, tetralogy of Fallot, TGA, TAPVC, tricuspid atresia, and truncus can be detected by this pulse oximetry screening. So, either these babies are presented with hypoxia or a cyanosis or a shock. There are few studies which shows that impact of pulse oximetry screening for detection of a duct dependent lesion in a congenital heart disease. This is a Swedish study, and also there is a European study which was published in the archives, is a pulse oximetry screening for critical congenital heart defect in asymptomatic newborn babies, a systematic review and meta-analysis. So, what this study shows that the sensitivity of a pulse oximeter for detecting the CCHD is about 75%. If you do a physical examination along with sensitivity of physical examination alone is 66%, but combined with the pulse oximetry it goes up to the 83%. This is by this study. So this is same as shown in this figure. Ki if you do pulse oximetry screening, the chances of the detection rate is very high. The sensitivity of pulse oximeter specificity is very high, and negative predictive value is also very high, almost 99.9%. So again, pulse oximetry screening is a non-invasive, low cost, and very easy to perform. So AAP also recommended the recommendation from the American Academy of Pediatricians also you should start using the pulse oximetry screening. So how to do it and what is its interpretation? Now a screen, I will show you the video. A screen would be considered positive, that you attach a pulse oximeter probe to the baby's right hand and then a right foot. First attach the probe and then attach it to the pulse oximeter, and then the signal after that the reading will be better. And any oxygen saturation, a screening will be considered positive when the SpO2 value is less than 90% and oxygen saturation less than 95% in both extremities on 3 measures, each separated by 1 hour, or there should be more than 3% difference in the oxygen saturation between a right hand and a right foot on 3 measures, which is generally separated by 1 hour. If the screening is considered to be negative, that baby has passed the screening, means if the saturation is more than 95%, more than or equal to 95% in either extremity, or less than or equal to 3% of absolute difference in the saturation between the upper and the lower extremity, would be considered pass. Okay, you can see in the video that the pulse oximeter probe was attached to the, initially was on the right foot, now it is on the right hand, and the saturation was 96%. Now it is attached to the right hand, and saturation is 97%. So more than 95% in the right hand or the foot, then it's considered to be and the difference between these two is less than 3%, less than or equal to 3%. It is negative for CCHD. Now this is the SpO2 in the hand is less than 95%, and in the hand and the foot is less than 95, and the difference between these two is more than 3%. It considered to be positive for the CCHD, and you should repeat the measurement after 1 hour. This is the saturation less than 90% in the 3 positive measurement 1 hour apart. If it is less than 90, then definitely it's considered to be suspected CCHD, and then you do the further evaluation by echocardiography. This test is not all the time positive for congenital heart disease. You can also see that there are some other reasons that the baby saturation is low. It might be because of some lung problem, or a baby with RDS, or maybe a baby with some congenital pneumonia. So there are 2 anomalies, but basically you need to rule out the other things, and then you say it is generally related to the congenital heart. Generally we do this test in a well baby which is going home and before the discharge after 24 hours of the life. Now this is the algorithm. A child in a well baby nursery more than 24-hour age, or shortly before discharge if less than 24-hour age, you first do the screening. Is just a summary of the what I have shown in the video. Less than 90% in the right hand or foot, or 90 or less than 95% in the right hand or foot, or more than 3% difference between a right hand and a foot, or more than 95% in the right hand or foot, or less than 3% difference between the right hand and the foot. Then you do a repeat screening 3 times, and after the 1 hour apart, and after the this test, first repeat after 1 hour, then you do a repeat after 1 hour, and then you say if it is first 2, then you say it is a failed screening and this baby needs to be subjected to the echo. And if this test considered to be passed, if the saturation in the all 4 limb is more than 90% and the difference is less than 3%. And why it is more on the right hand? It is more of a measuring the preductal saturation. So what is importance? What are the pros and cons about routine use of pulse oximetry screening? You can detect early detection of congenital heart disease. You can start the treatment early. It decreases the mortality. Detection of other congenital anomalies like PPHN, other anomaly like PPHN, sepsis, some RDS that can be detected. Any related condition to the lung can be detected early also. And what was the problem? False reassurance if the screen is negative. And again the parental anxiety, if you told them that this test is negative, positive, then definitely you need to undergo the echo. So in summary, a critical congenital heart disease occurring 2 per 1000 live birth usually require invasive medical intervention within the first 1 month of life, and can lead to the death and significant morbidity if not diagnosed early. Early detection is important to reducing the mortality and improving the post-operative outcome. Routine fetal ultrasound screening has led to the increased antenatal detection about 50 to 70% of all the CCHD. Postnatally, 20 to 30% of CCHD are still missed by the physical examination, as symptoms often occur later when the duct arteriosus closes. So even if a coarctation of a baby, you cannot detect it early if the duct is open, and by the time the duct start closing down, then the baby get decompromised. So even if you don't get murmur is not always present in critical congenital heart disease and may occur up to the 60% of a healthy newborn also. So murmur is not a criteria. Assessment of cyanosis is unreliable for detecting the hypoxemia. Now this pulse oximetric screening is widely available. It is accurate method to objectify and quantify the oxygen saturation, and thereby identifying the clinically undetected hypoxemia that occur in majority of a newborn in critical congenital heart disease. Once detected, heart defect can be surgically repaired as early as possible, and it is estimated that 85% of a neonate who undergo surgery with CCHD will reach into the adulthood. So this is all about the use of a pulse oximetry. So what is in summary that we should all start using the pulse oximetry, and it should be incorporated in your discharge booklet that we have checked the saturation of right upper limb and the lower limb, and you should write down on the discharge paper, so that even if the test is become positive, you can subject the baby to the echo and you can diagnose it early. And it is a wide based accepted things all over the world, and there is also a guideline which has been will come up in the by NNF and the IAP also, that we should incorporate this practice in day-to-day practice.